The first industrial symposium is supported by Roche, and the topic is undissectable HCC. Can we take this bull by the horn? I'd like to invite our moderator, Dr. Bhushan Nemade, and we have panelists, Dr. Jayant Gawande, Dr. Lieutenant Colonel Bhupesh Guleria, Dr. Parimal Lavate, Dr. Shraddha Patkar, Dr. Mukul, and Dr. Kunal Gala. Over to you, sir.
A warm good evening to everyone. I'm Dr. Jyoti Podar, oncologist from Roche. I welcome you all to the brainstorming session of hepatocellular carcinoma. As we all know that the world of still unfathomable and the treatment is challenging. It involves multiple fraternities unlike any other carcinoma. So without wasting much time, I would like to invite Dr. Bhushan Nemade, clinical oncologist from Nashik. We have Dr. Jayant Gawande, medical oncologist from Aditya Birla Hospital, Pune. We have Dr. Parimal Lavate, renowned gastroenterologist from Jahangir Hospital, Pune. Dr. Mukul Mutatkar, interventional radiologist from Pune. Professor Dr. Shraddha Patkar, who is a hepatobiliary surgeon from Tata Memorial Hospital, Mumbai. And Dr. Kunal Gala, Associate Professor, Interventional Radiology, Tata Memorial Hospital, Mumbai. Over to you, Dr. Bhushan.
Good evening, everyone. So I think everyone is on. I think one medical oncologist is missing from the panel. So we have only Jayant with us. So you will be having a lot of questions. So, but as it is a multidisciplinary approach, it is a great pleasure to really welcome everyone on the board. So we will be discussing one case. This case is given to by Roche team, and we will be discussing whether whatever has been done for that particular patient is something better we can do for those patients or not. So as rightly said, we all know that the three radiation, medical and surgical oncology are very important branches in managing any cancer. But I would say that hepatocellular carcinoma is one cancer where interventional radiologist and even a medical gastroenterologist are very, very important in treatment decisions. And many of these patients are first landed up with gastroenterologist, then referred to interventional radiologist, and then they land up with either medical oncologist or, for that matter, radiation oncologist. So coming back to the case, we have this 62-year-old gentleman with history of hypertension, diabetes, which is under control, and hypercholesterolemia, which is also under control, and non-critical coronary artery heart disease. Patient is alcoholic and had alcohol-related cirrhosis for 5 years. He has been diagnosed to have hepatocellular carcinoma in Jan 2020, and that is on basis of CT scan, triple phase CT scan. And there, on the CT scan evaluation, there were 2 lesions. One was in 6 centimeter at segment 5, and another was 2 centimeter in segment 8. So the further evaluation was done. AFP was 1054. I already told you the triphasic CT. Other metastatic workup, there is no extrahepatic spread, there is no metastasis. Child score was B7 and BCLC stage 6. So let me go to the surgeon first. Are you enough with the staging investigation, or you want to add something?
So if a patient is non-cirrhotic, triphasic CT scan would probably suffice. On the other hand, if a patient is viral positive, the CT is also showing features of cirrhosis in terms of nodular surface of the liver, splenomegaly. And there are presence of 2 lesions. I would add a contrast enhanced MRI to make sure that we are not dealing with some other lesions which may be missed on CT scan.
So you feel that contrast enhanced MRI is better in picking up some small lesion as compared to triple phase CT?
In a cirrhotic patient.
In a cirrhotic patient, okay. So coming back to the gastroenterologist, because they see a lot of cirrhosis patient coming to their follow-up, when you will really advise patient to undergo biopsy if you see multinodular cirrhosis and CT scan says, let's suppose 1 centimeter nodule in liver, which was not seen previously. So how will you go about it?
So we go by the standard guidelines. Basically, rarely do we do a biopsy for a hepatocellular carcinoma. And our choice in the hospital where I work is primarily a CT scan of the abdomen. And like it was mentioned, for certain patients, we do MRI with angiography. If there is a doubt regarding the diagnosis and the washout patterns in these patients, these are the only situations where we practically do a liver biopsy. Otherwise, we don't see. One thing which is not mentioned here very prominently is the portal vein and whether there was obstruction.
No, there was no obstruction.
So I
Because
assume
everything
that
is
there was
clean.
none.
Yes, that is not involved. So there is no portal vein involvement, and there is no extrahepatic spread. There is no lymphadenopathy, adjacent lymphadenopathy. So 1 centimeter newly diagnosed lesion, do you biopsy or you will do AFP is so high, so you will not biopsy this patient, correct?
No, we won't biopsy.
Okay, if let's suppose AFP is 30 in this patient, then what?
Then we would think of doing, obviously.
So whether you will do it or you will
See,
think of
because
doing it.
if you look at this patient on his CT scan, there is no mention whether this liver is really cirrhotic or not. Other
No,
thing
it is cirrhosis. It is diagnosed cirrhosis.
Fair enough. But he is an alcoholic who has been having this disease for the 5 years,
Yes.
last 5 years. And overall there is no ascites or anything. So overall it is a fairly stable disease. And definitely we would want to try and cure this patient of this, and that is why the histopathology can become important.
Yeah. Dr. Jayant, do you do biopsy when AFP is normal? Probably, let's suppose this patient is non-cirrhotic. AFP is 20, alcohol history.
If it is not a high-risk patient for HCC and the CT findings are not contributory, I wouldn't biopsy.
Okay, okay.
So I would like to add upon,
Yes.
so whenever there is cirrhosis with classical features like arterial enhancement, washout and a delayed enhancing capsule, so that's a classical feature of HCC, we don't need biopsy. But whenever there is atypical features or you are suspecting coalescent tumor, you need to do biopsy at that time. And if a patient is not cirrhotic, 2 imaging modalities are required to characterize as HCC. If both imaging are having classical features, then biopsy is not required. Biopsy is required if there is some atypical feature or both imaging modalities show indeterminate features.
So
that is the time.
Generally, you means that LIRADS 5 doesn't require
Yeah.
biopsy, LIRADS 1, 2, 3 doesn't require biopsy, LIRADS 4 probably requires biopsy. Correct?
So not at all. According to LIRADS is applicable only in cirrhotic livers.
Yes.
So LIRADS says that if it is 5, that is characteristics, you can go ahead and treat those patients. But for LIRADS 4 lesion, either you can observe or you can do a biopsy. So these are the 2 different.
Correct. Absolutely, I agree with you. Jayan, do we really see LIRADS in our clinical practice, like as a medical oncologist?
So, to be honest, we see all patients in a very advanced stage.
Yes.
So, no, ideally we don't see any
Okay.
LIRADS.
And this AFP more than 1,000, does it ring some alarm in your mind? Or for that matter, even Shraddha, you can take this question. AFP more than 1,000, whether surgical candidate or not. I will come back to that question, whether it raises an alarm.
So first, before one more point I would like to add in terms of biopsy is that a surgical opinion is warranted before you go ahead and biopsy for any patient, because if you have a mass with whatever histology, if it is eminently resectable, no surgeon would want to know what it is except for prognostication and maybe adding a lymphadenectomy if it's a cholangiocarcinoma. Coming to the second question about whether AFP, very high levels of AFP raise an alarm, it is mainly for prognostication and a thorough metastatic workup rather than a diagnostic point of view. And also for patients who are likely to be transplant candidates, AFP definitely has a role in prior estimation.
So more than 1,000, you will not post or you will not think of doing transplant, or what is the prognostication?
No, the rule of the thumb of which transplant surgeon follows is if it is non-metastatic with a very high AFP levels at presentation, they would probably subject it to some kind of downstaging.
No, what do you mean by high level? Means like there has to be something. What you follow in your practice?
We don't
High
do
level.
transplants, but transplant surgeons, they usually follow anything which is more than 1,000 as a cutoff for not going ahead with an upfront transplant.
So as rightly said, biopsy is not required, many of the patient, and whenever there is a doubt or let's suppose it's not matching it with your clinical history, then you should do biopsy. Jayant, a question for you. Because we are doing a lot of NGS, lot of investigations now on biopsy. How will you do that once the patient gets liver-directed therapy at later date?
So, as of now, there are no biomarkers which will help us guide in any therapeutic management of the patient. So, as such, we don't do any NGS, especially in HCC patients at least.
Okay. Coming back to the question to the gastroenterologist, Dr. Parimal can answer this. How do you follow up a cirrhosis patient? Like the patient is alcoholic cirrhosis or for that matter viral cirrhotic patient. How do you follow in your clinical practice?
So we actually, there are differences in guidelines, but in our practice we follow both alpha-fetoprotein and imaging. Or at least one CT scan of the abdomen we do when we are faced with a patient with cirrhosis, because sometimes we are in for surprises. But by and large, it is ultrasound and alpha-fetoprotein. Now, whether you should use two or not is controversial. We won't go into it. But we do use both of them, and we do it fairly religiously 6 monthly. And the best thing we do is to write down a protocol for the patient, like December 22 ultrasound alpha-fetoprotein, June 23 December, and so on. We at our center find hepatitis B as the main cause for hepatocellular carcinoma, and we have not found too many of patients who have alcoholic cirrhosis as a cause. And staging, of course, we follow the BCLC.
So coming back to the follow-up, sir, do you find any difference for taking a follow-up? Like if it is a co-infection, you will follow more judiciously. If it is HBV, it's HDV. You see HDV patient in India?
HD we don't see. But I would like to add here that for hepatitis C, the situation is a little different, because even if you have cured a patient of hepatitis C and he is viral negative for 6 months, still you are supposed to follow these patients very religiously for development of HCC, because even after the virological cure, you can get development of HCC. But there are certain rarer disorders in which this can be more common, and we do rarely encounter them, like hemochromatosis and so on.
Okay. So which staging, question for everyone, which staging do you follow in your practice?
I doubt if anybody is following anything beyond BCLC.
BCLC.
Along with BCLC, have now moved on to the Hong Kong liver cancer staging, because in our practice, if you actually go strictly by the BCLC criteria, you will find that less than 20% of the patients we see in clinical practice will actually be candidates for surgical resection. And BCLC is mainly developed by Western countries. Our patients are different. They behave more like the Eastern population, which is the Hep C, Hep B positive. And HKLC is actually a more pragmatic and a practical staging system.
Okay. And if let's suppose this same patient comes to you, now is this patient resectable for you?
So
2 lesions, level, I will just read it, 5 centimeter lesion, level segment 5, 2 centimeter lesion, segment 8.
So for defining resectability in HCC, we have to look at two folds. First, there would be tumor characteristics, and other would be the patient characteristics, because this is, HCC has come up in an underlying damaged liver parenchyma. So if the tumor is, there are certain features of tumor. First of all, now size has gone out of criteria, though that is why the BCLC system was considered to be restrictive, because they use size as one of the criteria. We know that large HCC, if resectable, can do well. The other thing is multicentricity. Again, either whether it's lobe limited or bilobar. If it's bilobar, obviously you can't go ahead with a surgical plan. And two other things, whether there is vascular invasion, and if at all, again, whether lobe restricted to a segment, whether it is the segmental branches or coming onto the main portal vein, is the IVC free, and lastly, extrahepatic disease. These are the tumor characteristics I would look at. If a patient is fitting into a resectable criteria based on tumor, but is not fit surgically, because either he's advanced child stage, has comorbidity, has poor PS, then even though the patient may be technically resectable, it is not, he or she is not a surgical candidate.
Now this patient, no extra hepatic spread, segment 5, segment 8 involvement, cirrhotic liver, but functional. Like there is no bilirubin, the left is not deranged, PTINR is normal, BCLC, B7.
How much importance do you give for varices?
Yeah, that is I'm asking.
Yeah, so varices definitely, if they are mild grade 1 varices and there is no history of prior decompensation or bleed, then those are the patients whom we would go ahead. One thing I forgot to mention in resectability is also the future liver remnant, which is going to stay back after we resect. So if a patient is again technically resectable, but the underlying liver dysfunction is such that you're not going to have an adequate FLR, then this patient won't be a surgical candidate. In this, I would again like to have a look at the CT scan, make sure that the FLR is adequate, because the child B7 worries me a little bit. That patient is at an extremely high risk of decompensation and with almost double the mortality risk as compared to if a patient was child A. And what our philosophy over the period of time is that if a patient has borderline child per criteria, subject them to some kind of liver-directed therapy, downstage them, basically see whether the liver is able to handle the stress of that treatment, and then go ahead with surgery.
Do you consider this patient for upfront transplant? Because you are doubtful about resection, whether liver will get decompensated. So is this a patient for upfront liver transplant?
He or she would fit into the extended criteria for transplant if at all.
What are the extended criteria? Can you just elaborate?
So the classical Milan criteria had the size limit of 5, had less than 3 lesions, and now there are numerous criteria. Actually, for living donor, there are no criteria only. You can go up to any size of tumor, and if you have a donor, basically you are eligible for an LDLT. So this is not what we follow, but the UCSF is one of the extended criteria when you have the number of lesions which can go up to 8, the size is more, and the cumulative size does not exceed 10 centimeters. Those are the ones who are fit for extend.
You made out a very important point, and let me come to Jayant. She has talked about neoadjuvant treatment. And two questions for you. What neoadjuvant treatment you will prefer before resection? And question for you, Shraddha, what you want your colleague to prefer which neoadjuvant treatment before doing for a liver resection? So both way question I am asking. So Jayant, first to you. What neoadjuvant treatment you will do for this patient?
So as of now, we don't have any robust data for any neoadjuvant therapy. Whatever we have in systemic therapy is for immunotherapy working well than TKIs. Okay. So maybe immunotherapy I would choose.
So you will prefer systemic therapy, not a liver-directed therapy as a probably first. I am asking about general neoadjuvant approach. It's not only neoadjuvant chemotherapy.
So for downstaging, arterial-directed therapy would be better.
Which? Sorry.
Any arterial-directed therapy.
Oh, any. So you prefer TACE like arterial this.
Yes.
Shraddha, what you will really ask your interventional radiologist or for that matter oncologist to do?
I would agree, because if it is BCLCB, I think transarterial chemoembolization as a downstaging or neoadjuvant as a bridge to surgery would be the way to go.
Now let's go to the interventional radiologist. Now this patient comes to you for neoadjuvant approach. You have option of RFA, you have option of MWA, you have option of TACE. What you will do for this patient?
Or TARE.
Or TARE, yes. Or combination. Let me give you more confusing picture. You have a combination also available. TACE plus RFA, TACE plus MWA.
So first is if patient is affording, can spend 2 lakhs of rupees.
Yes.
So then definitely TARE is much better with the advent of radiation segmentectomy and lobectomy available these days. We are going up to 200, more than 200 Grays to the liver, so that it gets auto-string and there is hypertrophy of the opposite side. That is one. If patient is not affordable, so then there are a couple of options. So then you can downstage with TACE and then do ablation later on, either with microwave or RFA. So that would be my option available.
Any criteria depending on size or numbers of lesions, whether what you will do particularly?
So for TACE, it's either curative option or a palliative option. Here it is right limited disease with single lesion 6 centimeter and another lesion I think 2 centimeter. One
is 5, another is 2.
So 5 both can be done TACE, and then we can do ablation for both the lesions.
Okay.
Actually, this patient, my choice would be inclined towards TACE actually, rather than doing a TARE for this patient.
Yeah, even I agree.
I mean, I would not just go by the patient's finances and say that he is okay affording, so we'll do a TARE for this patient. I think TACE may be a better option. I wouldn't know what.
I would agree with that. I would go with TACE, and then maybe repeat a TACE if required. But
Sir, this patient is to be planned for surgery, let's suppose. So do you do blunt TACE, just blunt embolization, or you will do proper TACE?
No,
for this particular patient?
Proper TACE.
Okay, so you feel there is no role of blunt embolization currently?
No, not at all.
So it has to be TACE, it's just not embolization. Okay, why not MWA? It is a very good results of RFAs and MWA multicentric lesion. Probably size is little bigger. you do RFA for less than 4 centimeter, 3 centimeter, but you can have multiple tumors in, like 3 tumors can be very well addressed by RFA or for that matter MWA. I know MWA is not very common and done in India as it, but why not RFA? Any other specific reason why TACE?
So since there are 2 lesions, so you need to downstage the tumor as well, and the size of the tumor is more than 5 centimeter and another is 2 centimeter. So to have better margins for that bigger lesion, we need to do either transarterial therapy first, followed by ablation, either microwave or RFA, whatever.
Anybody for radiation, SBRT, proton beam, we have proton beam in India too are there. So anybody like, see, patient can afford anything, so can afford even proton also.
I think we should go more by the guidelines and what is to be done for that patient rather than what the patient can afford.
SBRT is approved. You can always argue on a proton beam, but SBRT is probably the approved and not as such TACE. TACE has lot of evidences and very strong. So I agree with you. Probably I would also go ahead with a TACE on this particular patient, but just for a discussion I am raising this question.
Okay.
So this we already discussed. And how many tests before going for surgery? Generally you do it in your clinical practice. How many tests you generally recommend for patient? If let's suppose patient do not want surgery nowadays, just wanted a test, how many tests generally you do before referring for a systemic treatment?
So the guidelines and recommendations says that you can do TACE as much time as possible. If patient decompensates, then there is role of some other modified treatment.
But I will argue with it that once patient become decompensated, there is no other treatment which will work.
So the guidelines till now has shown that the TACE has a good result. So you need to continue TACE as much as possible. Then you can go with some other modified treatment. Okay, Jayant, your take, when you will want your local, like the interventional radiologist or gastroenterologist refer this patient to you for systemic treatment. So we'll come what systemic treatment at later date, but you will want, when you want to give systemic treatment for this patient.
So I would like that the patient should have a preserved liver functions when he comes to me.
Yes.
Because all the therapies and their efficacies are proven in preserved liver function. So I would like that the patient is monitored carefully when he is undergoing TACE, so that there are no defined guidelines, but there are some Japanese guidelines which tell you that the patient is not responding to TACE. So if there is less than 50% necrosis after your TACE, or if there is a new lesion coming up, or your EAFP is not falling down, maybe your TACE is not working, and it's better that the patient is shifted to systemic therapy.
Yeah, so that's the matter of debate, because it is being mentioned that till you do liver directed therapy and patient is fit for you, you please go ahead. That's what the guidelines actually really says. But on the other hand, we all know that even the guidelines for systemic treatment also says that till the patient liver function is preserved, you should give the systemic treatment. So that's what the big disconnect, and where I would feel the MDT discussion is very, very important in management of SCC.
Is there any size restriction for TACE?
No, actually bigger tumor you can do TACE. If actually smaller, you should do RFAs and MWAs. So this patient...
I'm speaking of like say 5, 10, 12, 14.
So
you need to do depth TACE over a conventional TACE. If there is single lesion, larger tumor, then you do depth TACE, because the the drug penetration into the tumor is much better with depth, because the particles are uniform size as opposed to C-TACE. So that's the only advantage.
No, the other thing that you can do if you're worried about decompensation is to do part of the tumor each time.
Yeah,
you stage the whole thing.
Yes. So coming back to our case, our patient underwent TACE twice at the gap of 3 months. After 6 months, 5 centimeter lesion reduced to 2.8 and 2 centimeter lesion remain unchanged. And now on evaluation, once again, there was no esophageal varices, no ascites, no encephalopathy, child pook class A6 now. Now what we'll do? Once again, liver directed therapy, or Jayant, you want to do something now, systemic treatment, because one lesion has not responded.
So as I said, this sort of fits into a TACE refractory case. So I would not like to continue with TACE. I would like to take an opinion of the surgeon, whether this fits for a transplant or not.
Okay.
Otherwise,
Shraddha,
systemic
he will
therapy.
refer to you. What you will
So
do?
before going on to transplant, actually this patient has stood the test of time in terms of biology as well as
Yes.
the improvement in liver function. So
Correct.
if there is adequate future liver remnant, I would like to offer this patient surgical resection. Even if the future liver remnant is not adequate, this patient also qualifies for an augmentation procedure. I would do a portal vein embolization, again see if the FLR increases, and then if surgery can be offered, nothing like it. The patient is, you've given a curative option for a patient whom 6 months back you were thinking in terms of a bleak scenario with a child B status.
Okay, I agree with you. This patient should be offered surgery. But let's suppose this patient is not willing for surgery because he feels that non-surgical treatment is giving him a good quality of life. Now coming back to Jayant, what would be your systemic treatment of choice for this patient?
So he's in child book A right now.
Yes.
Preserved liver function.
Yes.
And only 2 lesions in the liver, no extrahepatic disease. Not willing for any curative therapy. So systemic therapy I would like to prefer is atezo plus bevacizumab.
Atezolizumab plus Bev. Okay. So coming back to the what really data says, there are a lot of drugs has been
One
tried.
second.
Yeah.
One second, he still could be a candidate for ablation.
Definitely.
Rather than starting systemic therapy is for extrahepatic disease. It is localized tumor. You need to burn the tumor either with RFA,
You did taste. What you will do now to ablate
either
it?
burn it with RFA or a microwave or cryo or whatever.
Okay. So you will once again do apart from taste, you will once again do other tests. So are you? Do you feel the patient who has not responded to test will respond to MWA, RFA?
Yes.
Actually, the patient has responded. One lesion has
one
increased
lesion.
to less than 3 centimeters.
Yes,
There is another
yes.
lesion which has not responded to taste but is still less than 3 centimeters. So
Yeah,
both
so-
can be ablated.
So what are your criteria to label it as a true taste refractory tumor?
So when the response is less than 50% necrosis on MRI or CT scan, when you do on a follow-up imaging, so when it has not responded to 2 tastes, that is the time you call it taste refractory. Okay, that time you can either choose over if right now he's a curative, so you can just burn the tumor and burn the 1 centimeter margins as well. Okay, so then that becomes a curative option. If he does not respond and he want to go for any other treatment, then TARE is another option.
Okay, agreed. Now let's suppose this patient has developed one lymph node in porta. Now, no local treatment, correct?
No local treatment, only system.
Okay. So coming back to the systemic treatment, these are the various studies which has been done since ages, and the first drug which has shown some benefit was sorafenib. 2008, 2009 it was approved, and there are lots of negative studies. If you really see, the red one are the negative studies, the green one are the positive studies. So whatever has shown response after 14 years of sorafenib, then the drug came, the combination of atezolizumab and bevacizumab better than sorafenib in terms of overall survival and all other features. There was a drug called as lenvatinib. Your views on lenvatinib as compared to atezolizumab and bevacizumab, Jayant, for a systemic treatment?
So if a patient fits the criteria for the atezo-bev trial, I would like to go ahead with that because of the better response rates which are seen with the IO-TKI, with the IO and VEGF inhibition,
Okay.
the better overall survival as compared to lenva or sorafenib. That would be my first choice. Otherwise, among sorafenib and lenvatinib, there is a general feeling that lenvatinib is better tolerated by the patients. So,
Yes. Do you really see in your practice that lenva is better tolerated than sorafenib, and what dose lenva you give and what dose sorafenib you give?
so lenvatinib, I follow the usual guidelines. If it is more than 60 kgs, I give 12 milligrams, less than 68 milligrams.
Okay, and what is your...
Sorafenib, we usually don't start with the full dose. We
Yeah,
start
so-
with 400.
So you start with 200 milligram BD, then
Yeah, and
400 full dose once tolerated.
No,
Okay.
I can't reach 400 in most of
You
the patients.
never
at least
reach
600.
that. Okay, I agree with you. Generally, very few patients tolerates 400 milligram BD dose. Second line options, we'll come to that, but there are also a lot of studies on second line, and very few have shown some benefit. So the lot of impact has already been done by atezolizumab and bevacizumab. So in order of decreasing impact, atezolizumab and bevacizumab fares better than nivolumab, fares better than lenvatinib. In second line, regorafenib and ramucirumab or cabozantinib fares better than other treatment modalities available. Mind you, these are till 2021. 2022, IO has come as the preferred second line treatment. I will come to the IO part at later this thing. So combination is a way to go for systemic treatment as far as SCC and RCC is considered. Now we are moving from single drug to combination of either IO plus TKI or IO-IO combination. And this is a rationale. The combination actually TKI-IO combination converts cold tumor to hot tumor, so they are more liable to damage. That is was the postulated hypothesis which is there. So our patient underwent the same treatment what Jayant has advised, atezolizumab and bevacizumab. After 3 cycles, the patient was evaluated with triphasic CT scan, and the two lesions of size 1 centimeter were seen. AFP has dropped down to 247. Patient was continued with atezolizumab, bevacizumab up to 9 cycles. The CT scan showed no lesions after 9 cycles. Patient is on maintenance atezolizumab and is on cycle 16. Now question to you, Jayan. Till how many months, years, or till life you will continue atezolizumab? Patient is affording, no problem.
So if the patient is affording and tolerating, I would like to continue till progression.
Bevacizumab also?
Yes.
Till progression?
Till progression.
What are the side effects you will look for before stopping it? For ATO as well as for bevacizumab?
So for ATO, we have to look at the immune-related adverse events that the patient has.
Okay.
And with BEV, the regular VEGF adverse events that we see, such as bleeding, hypertension.
Okay. So coming back to the very important question, do sorafenib still have some role in your clinical practice? Let's suppose I will give you one scenario. Patient is SCV positive, child PUG B7 or B8, or for that matter not in a very good GC. What you will do? Hepatitis C related SCC. Little googly for you.
So I would go for sorafenib in this case. You said B7.
Okay. So are you comfortable using B5, 6, 7 with lenvatinib or not? You want to keep lenvatinib only for A?
So if you strictly follow the data, then it is only for A, but you can extrapolate and give it in B7 also.
Okay, okay. So the study which Ambrem 150, which everyone is talking, is the same study, and this is a very important, which is I think the hallmark. In spite of major vessel invasion and extrahepatic spread, where sorafenib has failed miserably, the overall survival and median PFS, everything is actually doubled. So in a bad risk patient, which was always thought to be like very, very bad, and patient will survive for 3 to 6 months only, the survival is doubled. So your views on this bad patient, which everybody don't want to treat this patient. Surgeon don't want to treat, IR people don't want to treat this, eventually land up with medical oncology.
So the point to remember is HCC, there are 2 diseases. One is the HCC and the other is the liver disease.
Yes.
So if the liver is well preserved, these are the sort of results you can expect in a patient with a bad HCC disease.
Yes.
Actually, I'll add here that if you have, there are 2 etiologies, which is alcoholic and the second is hepatitis B, where if the person is abstained and if you are treating them with hepatitis B treatment, there can be definitely an upgrading in the child's status. And then your decisions can change over time. Like what you felt was a hopeless situation, like he said, where both were bad, the cirrhosis and HCC. Now you find that the cirrhosis is much better because he stopped alcohol, or you have treated for hepatitis B. And then there can be change in decisions in these patients.
Yeah. Jayant, your guidelines for managing a side effects and how you look for varices when you give atezolizumab, for the audience you can tell.
Yeah, so before starting atezo-bev, you have to look for portal hypertension, especially for the esophageal varices. And if there are varices, you have to treat them as per your institutional guidelines before you can put the patient on bevacizumab to mitigate the risk of bleeding. Patients with cirrhosis also have another problem of thrombocytopenia. So there are no strict guidelines when you can or cannot give, but the general practice is that we give usually above 75,000. Below 75 we should be cautious. Then patients can be on anticoagulation for portal vein thrombosis.
Yes.
That is not an absolute contraindication, but then in such cases you have to be careful when using VEGF.
Do you recommend prophylactic banding before posting patient for, and what grade, like grade 2 varices? Do you tell gastroenterologists to do prophylactic banding? They are not bleeding.
I would take the opinion of the gastroenterologist.
Gastroenterologist, coming back to the
anything.
gastroenterologist.
We would do the banding.
We'll do the banding.
It's a
before,
simple
like.
procedure.
Okay. Now, another very interesting data of first line, the Himalaya study. Any comment on this? This probably may be an alternative to atezolizumab, bevacizumab as a first line treatment, or too early to comment?
Yeah,
IO combination.
So I think the follow-up is a bit short. We may have to wait for some mature data, but this is also a promising trial.
Yeah, it is a promising trial probably, and it is already being approved as a first line. But let me tell you, it is already being approved, but no data as such robust like what we have IMBRAM 150. There is one more interesting study. This is probably, will also be a first line. There is already a interim data has come up of this, and survival is still not reached. So we really need to see the data of this study. This is a combination of IO plus lenvatinib. This is the only study where standard arm is lenvatinib. You need to, this study is very, very important because lenvatinib is a standard arm now for this study, which is not sorafenib. So this study will answer a lot of questions, and whether we really need to see whether this will be a first line after the final results. Little busy slide. This is the BCLC guidelines 2022 NEJM published in NEJM. So whatever we have discussed, I would request everyone to go through, and it's clearly very good summarization of whatever treatment modalities in hepatocellular carcinoma. Coming to Jayant, the last question to you. Once you give atezolizumab and bevacizumab, what would be your second line treatment if patient progresses?
So that will depend upon how fast the patient has progressed.
In 19 cycles. Patient has taken 19 cycles. Very good response to IO.
Then a TKI can be a second line option.
Which TKI?
I would prefer lenvatinib.
No data.
Yeah, there's no data for any treatment post.
So you're right. You're right. Absolutely right. There is absolutely no data what will happen after you give TKI after IO TKI combination. However, probably you're right. I would probably select cabozantinib as a second line, or for that matter even a single agent IO, because so much of IO after IO we are not sure. One very important thing, how many of your patients who are underwent transplant do you prefer IO to be treated with IO, those patients should be treated with IO, or it is a contraindication for giving IO?
So as such, it is a contraindication to give a IO in a patient who has undergone a transplant, but there have been case reports where patients have tolerated IO.
I would like to share the experience. I had one doctor patient, I have actually, who is underwent transplant in Pune, had a portal node, unresectable. There are 2 nodes, retrocrural 1 node. Patient underwent SBRT, disease-free interval of 8 months, started on lenvatinib that time also, intolerant to lenvatinib, not even a 12 milligram he was tolerating. Then thousands of doctors shown, tons of millions of opinion taken, and eventually it was decided to re-challenge this patient with IO. Patient received first IO, no problem. Second IO, rejection. We are fighting with, there is biopsy done. Now HGPTs are in tune of 5,000, 6,000. So,
but I think take-home message should be what you said.
Yes, yes. So please, you have to be very, very careful. There are some studies which shows that you can give IO after transplant. This patient was managed by MDT. The transplant physician was involved from day 1. We titrated the dosing of Tacro, Evro, whatever the drugs were on. But unfortunately, we are facing a graft rejection. So you have to be very, very careful for offering IO in a post-transplanted patient. So I think that finishes. Any questions or any comment if anyone want to give? Thank you panelists for a nice interaction.
Sir.
Yeah.
So how do we manage the patient if the same patient would have a VP, say VP1, a thrombus in VP1, and if there is a thrombus in VP4, the management would, my question is how?
So ultimately, a vascular invasion in HCC portends a poor prognosis. We try to do our best. If it's a segmental and lobe limited, try to offer resection. Having said that, overall the outcomes even after resection or even people who have done transplant for these patients is not great. Okay, so something coming on to the main portal vein, I wouldn't even venture thinking of it. Maybe a segmental something where after explaining to the patient that this patient is still not going to have the best outcome as compared to a patient who didn't have any vascular invasion, maybe or on that side and give the benefit of doubt. That's about it.
If surgery is not possible, then this patient should be offered SBRT because that is the one which will work on a tumor thrombus. So this is an ideal indication. If there is no surgery contemplated, test cannot be done, this patient should be offered SBRT or proton.
So if there is a option of tear versus SBRT?
So tear would be the better option because the particle size is smaller. You can invade into the tumor as well as into the portal vein. So with the high dose radiation. So if whatever part is not getting covered with tear, you can give SBRT to that focal segment. rather than giving to whole of the liver, because the dose of radiation what we reach is around 200 to 300 grays, and externally it is just 60 grays to 90 grays. So that's the difference. So whatever area we can't cover, maybe we can add up SBRT.
Thank you, sir.
Thank you, panelists. Thank you.